Okay, I think we can start now. Yeah, okay. So, good evening, respected seniors and my dear colleagues. It gives me immense pleasure and privilege to welcome you all on eve of World IVF Day, a day that honors one of most remarkable milestone in field of reproductive medicine. Today, we not only celebrate the scientific breakthrough that have made IVF a reality, but we also pay tribute to all our clinicians, embryologists, researchers, scientists, nurses, counselors, and our patients who embark on this journey with strength and hope. And this is our tradition to start everything doing Saraswati Puja. So, can I request Yukti? Can you start Saraswati Puja?
Yes, ma'am. Yes, ma'am.
Meanwhile, she is starting. I just want to tell you कि इसका अर्थ क्या होता है सरस्वती पूजा का. इसका अर्थ होता है कि जो चंद्रमा के समान सफेद रंग, बर्फ के समान सफेद रंग और कुंदन के पुष्प के समान सफेद रंग के वस्त्र धारण करती हैं, जो सफेद रंग के कमल के ऊपर बैठती हैं और जिनके हाथों में वीणा विराजमान है, उनकी पूजा ब्रह्मा, विष्णु, महेश सब देवता करते हैं. ऐसी माँ जो ज्ञान, विद्या और बुद्धि को देती है, हम सबकी रक्षा करिए और हमारी अज्ञानता को दूर करिए. So can you play युक्ति now? सरस्वती वंदना.
Yes, ma'am.
या कुंदेंदु तुषारहार धवला. Thank you, Yukti. Now, I want to request my dynamic chairperson, Dr. Sunita Arora, to give an introductory welcome address to our esteemed faculty and our national president and Dr. Sharda Jain ma'am, Dr. Renu ma'am, and all our seniors. So, Dr. Sunita Arora.
Thank you, Dr. Sujata. I welcome each and every one of you, all dear faculties, our President ISAR, Dr. Amit Patki sir, and Founder Secretary DGF, Dr. Sharda Jain ma'am. We are really delighted to have both of you with us on this platform today. Today is a very, very special day for us. It's eve of World IVF Day. We know that, and that's why we are here. And this time we thought little out of box to give our audience, our members, hearing about how IVF evolved over years, and we requested Dr. Sharda Jain ma'am is going to tell us some beautiful, interesting story, and Dr. Patki is going to cover how male fertility evolved over years. Dr. Renu is there. She's going to speak on how hysteroscopy evolved over years. So I'm sure we are all looking forward to this. And I welcome all chairpersons for the event, and Dr. Tarini Taneja, who is immediate past president, Delhi ISAR. Our chairpersons, Dr. Birbala, Dr. Deeba, Dr. Sujata, who is secretary, Delhi ISAR, Dr. Seema Prakash, vice chair, Dr. Shivani, vice chair, she is also logged in, Dr. Shelly, Dr. Deepika Logani, Dr. Vanna Gupta, Dr. Sushila. So with all of you, we just invoke blessings from Ma Saraswati. I will not take much time because we have so much interesting things to hear ahead. And I will request Dr. Yukti now to play a video message which was sent to us by our President ISAR, Dr. Amit Patki. Over to you, Yukti. Please play the message.
Yes. Good evening, all, and happy World IVF Day to all the faculty and delegates who have joined us. So our ISAR president, Dr. Amit Patki sir, has been very kind, and he has sent us a special message on this occasion of World IVF Day. Let's listen to this.
Hi, good morning. This is Dr. Amit Patki, your president at ISAR. 47 years ago, on the 25th of July 1978, A girl child named Louis Brown was born in England. What was special about this birth? It was the world's first IVF baby. And hence, every 25th of July, we celebrate World IVF Day. It is a celebration of the human mind and what science can achieve. What was thought impossible only a few years before that, to create pregnancy outside the human body. So let's celebrate World IVF Day by increasing awareness of infertility, by removing the stigma that haunts infertility couples, and advocating for easy access and affordable treatment to all. Let's celebrate World IVF Day by supporting the couples, by giving a patient hearing and listening to them with empathy, and encouraging mental health support to all. Let's celebrate World IVF Day by honoring the medical professionals, the embryologist, the fertility specialist, and the support staff who have dedicated their lifetime in sheer quest of this infertility. Let's support each other, let's increase our awareness, and let's make infertility a treatment that every couple, and let's empower every couple to have parenthood, because every pregnancy matters. So wishing all of you a very happy World IVF Day. Bye.
Thank you so much, sir, for the lovely message. That was very inspiring. Thank you so much. It was a great gesture, sir. Thank you.
Yukti, we can now proceed for the academic session, please. Please invite the chairpersons.
Yes. So I'll be inviting the chairpersons. So Dr. Bilbara Rai, ma'am. Ma'am is senior consultant and unit head, advanced gynae endoscopy surgery and robotic. She's a robotic surgeon. Ma'am has lots of awards to her credits and lots of publications. Thanks for joining us, ma'am. Dr. Tarini Taneja, ma'am. Ma'am is gynae consultant and laparoscopic surgeon at Taneja Hospital and IVF Center, Delhi and Muzaffarnagar. She is chairperson ISPAR Delhi State, vice president South Delhi IMA, and president Manzil-e-Rahat NGO. Ma'am has got the Lifetime Achievement Award and Nari Gaurav Award. Thank you, ma'am. Dr. Diba Zubair, ma'am. Ma'am is a consultant at Al Shifa Multi-Speciality Hospital in New Delhi, and she is also ex-assistant professor from KG Somaiya Medical College in Mumbai. Welcome you, ma'am. Dr. Sujata Agarwal, ma'am. Ma'am is our Delhi ISAR secretary and also the director IV Health and Infertility Center, South Delhi, Heart and Gynae Clinics, Friends Colony East. Madam has a lot of achievements and awards to her credit. Now I would request Dr. Rashmika to introduce our respected chairpersons. Dr. Rashmika.
Thank you, Yukti. I welcome Dr. Seema Prakash ma'am from UCMS. She's a fellow of ICOG and also the current chairperson of Breast and Cervical Cancer Prevention Committee of AOGD 2024-2025. Dr. Shelly Singh ma'am. She is the director of Fortis.
Please change the slide, Yukti. Dr. Shailesh slide, yeah.
Of Fortis La Femme. She is also the recipient of APJ Abdul Kalam Appreciation Award in 2018. I welcome you, Shelly ma'am. Dr. Deepika Logane. She's a senior consultant OBGY with Fortis Hospital and Sitaram Bhartiya Institute. Her interests lie in high-risk pregnancy and preventive gynecology, and she has many years of experience under her. Thank you for joining us today, Dr. Deepika ma'am.
Thank you.
Dr. Vandana Gupta. She is a senior consultant of OBGY at Max Hospital, Parparganj. She is the member of multiple OBGYN Society and the recipient of numerous awards, including the Distinguished Services Award, JP Rawat Memorial Gold Medal Award in OBGY. Thank you for joining us today, Dr. Vandana ma'am. Dr. Sushila Gupta. She is the Director and Senior Consultant OBGY at GNH Excel Hospital, Shalimar Bagh. She is the member of Breast Committee FOXY from 2019 to 2025 and also serves as an advisor to DGF North since 2018. Thank you so much for joining us, Dr. Sushila.
So thank you, Dr. Rashmika. Now we'll start with our first talk, which is on IVF in India by none other than Dr. Sharda Jain ma'am. She's a teacher of teachers. May I please request Vandana ma'am to formally introduce Sharda Jain ma'am, though she does not need any introduction. Ma'am, please
It's
do the
my privilege. It's my proud privilege. No, she has been a mentor and a guide and a teacher of teachers. She always says, do not introduce me, but she really needs no introduction. And a wonderful person at heart who has handholded all of us and carried us forward and brought us to this platform where we can all sit with pride and enjoy all the sessions, ma'am. We have been kind enough to give us support at each and every moment. Thank you, ma'am. He has given concept of Janini Suraksha Yojana and Asha worker to the government of India, and these two programs have been taken up very nicely. And now she is spearheading a movement for Viksit Bharat. So that is her aim now. So let us see what message she has to give us today on on the eve of World IVF Day. Welcome,
Yeah,
ma'am.
can I just add one sentence? I was just thinking how to introduce ma'am. तो मेरे दिमाग में सिर्फ ये आया कि जो ध्रुव तारा होता है दूर एक जगह स्थिर होता है तो सबको गाइड करता रहता है पूरा दिल्ली
Yes.
पूरा इंडिया मैम की एकेडमिक एक्टिविटीज को अगर सब ध्यान से सुने तो और कुछ करने की जरूरत नहीं।
बहुत हो गया भैया।
मैम ये आया दिमाग में क्या करूं?
Let the slide go.
Very right, Sujata. Very right. You are very right.
Can we have the slide off? Yes. I think so. Share. I think my great regards to Dr. Amit Patki, Dr. Sunita Arora, who had roped me in this particular presentation today. And it's a pleasure for me to, all of you know about the facts which I'm going to talk about it, but it is good to remember these facts on the eve of World IVF Day. So today I'm not going to talk about anybody else outside. I'm going to talk about IVF in India, the story of its progress, pregnancies, and parenthood. The early pioneer work in IVF ignored India. All of us know about it. The India's IVF journey began just 67 days after the world's first IVF baby, Louis Braham, who was born on 47 years ago on 25th July 1978. Dr. Subhash Mukhopadhyay created India's first test tube baby, Durga, in 1978. He remained unsung pioneer for very, very long years. He worked alone without the government or the peer support. Tragically, Dr. Mukhopadhyay died by suicide due to neglect by the colleagues, humiliation by the colleagues, humiliation by bureaucrats, our first IVF martyr. As for the scientific recognition of Dr. Mukhopadhyay his work was only validated posthumously when India's officially recognized Durga as our first IVF baby, 67 days after Lucy Brown. His sacrifice laid the foundation for India's ART journey. Later, Dr. T.C. Anand confirmed his work. When he was given this felicitation, he said, no, this is not mine. Dr. Mukhopadhyay deserves it. And he pushed for official recognition of Dr. Subhash Mukhopadhyay. Subsequent to Dr. Mukhopadhyay, Bharat's IVF milestones and the global recognitions have been India's first recognized IVF baby Harsha was born in 1986 in Mumbai under Dr. Indra Handuja, and Dr. T.C. Anand was her back support. Since then, India has become the world's second largest IVF center. We now have over 3,000 ART clinics in metros and tier 2 cities. India performs 3 lakh IVF cycles annually, up from just few thousands in 80s. ART success rate also has risen. It was 10 to 12% in 80s. It has gone to 40 to 50% live birth rates in top centers in the country. India's fertility sector is projected to cross 50,000 crores by 2030. As far as global pehchan of IVF experts, and India fertility specialists chair big bodies, ISMR, ISAR, FOXY, and have shaped ART guidelines. Many IVF scientists train doctors from Asia and Africa. We are capacity builders. Advances in evidence-based IVF practice. Word over, ICSI has revolutionized the male infertility. India embraced ICSI early. Today, more than 60% of the IVF cycles use ICSI for male factor cases. Pre-implantation genetic testing is now available in India at par with the global labs. Time-lapse embryo monitoring, the vitrification, the blastocyst culture are now routine in majority of the centers. As for the regulation and ethics are concerned, India was among the first Asian countries to have a national ART guidelines. Way back in 2005, the ICMR had laid these guidelines, and it had been all along advising us. The new ART and the Surrogacy Act came in 2001, 2022, now regulates IVF practice, donor gametes, surrogacy, protecting patients and children. The stronger regulation means higher trust by the community, and it also attracts global patients. India's unique strengths are high patient volume, huge workload, and a rapid learning curve for our experts. As for the cost effectiveness IVF is concerned, the average IVF cost in India is 1/5 of the Western countries. I again repeat, it is 1/5 of the Western countries without losing its success rate. Indian clinics serve not just domestic people, but global couples, and medical tourism in IVF and ART is increasing by over 10% every year. As for the social transformations are concerned, Dr. Patti did tell that IVF infertility had been a big stigma. Many people who are conceived with IVF do tell you that, do not write down on the files, do not put it on the discharge slip that I've had IVF pregnancy. But all said and done, IVF has ended the stigma for millions of Indian couples struggling with infertility. Now the single woman, the cancer survivors, the genetic disease carriers now have a big hope. Fertility preservation, both for eggs and the sperm freezing, is growing, both for therapeutic and social reasons, especially in urban India. Again, it has to catch up in a big way. Now, as for the heroes and champions are concerned, I did talk about Dr. Subhash Mukhopadhyay, remains our unsung hero, and every IVF specialist owes him the gratitude. Many quiet warriors are there, the embryologists, the lab scientists, who have worked very hard, who are working in silence for decades now. Early pioneers often face ridicule, raids at their home and the place of work, moral policing, and some face depression. And one of us, leader, had committed suicide. So the mental health support for ART specialists must be talked about openly, and we must not lose another hero for neglect. The solid Indian evidence. Now, multiple Indian centers publish in top journals, fertility, sterility, and human reproduction. Again, bring proud for all of us. Indian evidence supports unique protocols for PCOS, endometriosis, and tuberculosis-related infertility. Very successful. As for the innovations are concerned, low-cost stimulation protocols, minimum stimulation IVF for poor responders have been worked out by the Indian experts. The road ahead, from pioneers like Dr. Mukhopadhyay, who gave their lives for science, to a future of affordable, accessible, and ethical IVF practice. This is Bharat's India's journey, which is resilient, responsible, ready for global leadership. Let's salute our heroes, honor our evidence, and promise that no dream of parenthood shall remain unfulfilled for want of science, ethics, and the support by the Indian doctors. Thank you very much.
Thank you so much, ma'am, for walking us through the IVF journey and from the past to the future. And also, you were talking about the importance of mental health in IVF, especially. I think that is something very important and relevant in today's world. Thank you, ma'am. Thank you so much.
Thank you, ma'am, for giving us true facts and speaking straight from heart. So it really makes the base for us to carry it forward. And we will move on and we will take opinions from all our chairpersons in the end, and we will, request them to share their thoughts at the end of seminar, because all of them are going to stay with us. Thank you for your time, ma'am. Please stay back with us, because Dr. Amit Patki is again, going to give a very important talk on how male fertility evolved, which is so very important. Yukti, let's move on.
Yes. So after that lovely talk by Sharda Jain ma'am, let's go to the second talk, which is on how IVF has evolved since inception by our very own Delhi ISAR chairperson, Sunita Arora ma'am. So I would request Sushila Gupta ma'am to formally introduce our speaker.
I think that's not needed. Let's move on. Please allow me to share my screen. Is it visible?
Yes. Visible.
Yeah.
It's full screen.
So again, just like,
Make it full screen.
Okay, 1 second. Is it full screen now?
Yeah.
So just like ma'am spoke very general about IVF in India. So this is again, going to be very, very general talk on IVF journey till date, updates and advancements. So we all know the very basics, why it is called in vitro fertilization, because fertilization happening outside the body. In vitro means glass. So early experiments were all on glassware. Why it is called test tube baby? It is a misnomer actually. And the fertilization used to happen earlier also in petri dishes, but still it is called a test tube baby even now by general people. So let me take you through the milestones of early IVF and the key developments and breakthroughs. So as early as 1890, the first embryo transfer happened through Walter Heap in a rabbit. So it all started in animals, just like any other discoveries, inventions. IVF also started with rabbits. And in 1954-59, the first live birth in rabbit happened. Then in 1965, Sir Edward, he observed in vitro maturation time of human oocytes. And after that, first successful fertilization of human egg happened in 1969. So the story all began with the experiments in rabbits and having IVF, the rabbits produced through IVF, which happened in 1959. So we all know Robert Edwards, Bevister, Steptoe, all these people, these great scientists, they published in Nature the successful in vitro maturation and fertilization of human oocytes. And this was a major breakthrough demonstrating the possibility of human embryo creation in lab. In 1973, see, most of us don't know what happened in 1973 in Australia. We know that 1978, it was Louis Brown, the first IVF baby of world. But before that, in 1973, the first IVF pregnancy had already happened in by Monash research team in Melbourne, Australia. But unfortunately, it resulted in early miscarriage. So most of us don't know this, that 1973, Australia did the first IVF pregnancy, but that somehow did not continue. And then in 1978, it was Louis Brown, who was born in England, conceived via IVF by Dr. Robert and Dr. Patrick Steptoe. And the very first, this mother who gave birth to this IVF baby, the indication was bilateral tubal blockade. And let me tell you, at that time, the ovarian stimulation was not done, and this was done in natural cycle. And we should be proud that just, few days later, 3 months later, Kanupriya Agarwal, as Dr. Sharda Jain ma'am also mentioned, whom we know as Durga, she was born in Kolkata just 67 days after Louis Brown, created by Dr. Subhash Mukhopadhyay, who, could not be acknowledged at that time, but later on, yes, people did acknowledge his work. And he was denied recognition at that time because of bureaucratic harassment, which is a hard truth. So this girl, Kanupriya Agarwal, this is article from 2018. She was 40 at that time. So she's already 47. So just imagine, we all should feel proud that, just 67 days later, after the first child in the world was born, we had Kanupriya Agarwal as our own Indian IVF child. And this story of Sir Mukhopadhyay, this inspired the film Ek Doctor Ki Maut. So all of us must watch this movie if anybody has not watched yet. So in 1981, so we had our first baby through IVF in 1978. Again, a proud thing to say that US had first IVF baby in 1981. Then French had in 1982, 1983, first frozen embryo, first egg donation success was there. In 84, surrogacy embryo transfer happened. And in 1985, introduction of ultrasound guided embryo transfer was done for the first time. In 86, first oocyte freezing happened. And in 1988, first subzonal insemination pregnancy happened. In 89, vitrification of oocytes. So 86, this was slow freezing of oocytes. In 89, we had vitrification of oocytes, after which it really paced up, and so many cases are being done now. And pre-implantation genetic diagnosis, that also is not very old. In 1990, first live birth after PGT happened. And in 1991, GnRH antagonist. We know GnRH antagonist is a blessing for all of us. And we are doing wonders for PCO girls because of this particular molecule. So if we talk of ICSI, so ICSI, which is, very popular for severe male factor infertility, and we know that this has really changed the trends over years. It was pioneered by Dr. Gian Piero Palermo, who did this ICSI for the first time. And so 1990, as I said, PGT and pre-implantation genetic testing, it's a bliss for people who have genetic problems in the family. And all of us as IVF specialists, we are doing cases of thalassemia, sickle cell, and all those things. So now, we can give them thalassemia-free child to the couples who are suffering from thalassemia, sickle cell-free kids, even so many chromosomal balance translocation and all, people having recurrent abortions, and we are able to give them healthy baby with the help of PGT-SR. So we can look at the pace at which the technology is evolving. Similarly, PGT-A, which can be used for advanced maternal age, recurrent pregnancy loss, recurrent IVF failure. This is a huge advancement. Let's look at IUI history as well. So let me tell you, artificial insemination, initially it was used for male subfertility, and now we use it for unexplained and mild male factor infertility as well. But you will be surprised to know that IUI dates back to 15th century. It was documented in 1790 by John Hunter. And if you look at the milestones of intrauterine insemination, in 1784, first dog insemination happened. In 1939 to 53, preservation techniques came. In 1943 to 53, human insemination studies were published. So if we look at this, the sperm preservation, cryopreservation and all was started much earlier as compared to if we look at egg freezing and vitrification programs for eggs and all. So as IVF started evolving slowly, the IUI also, it became more and more refined over the years, because some technology like sperm preparation, advanced sperm preparation, preventing contractions in the uterus, this was something common between both the things. So IUI also advanced side by side. 2010, we know Dr. Robert Edwards, he was awarded Nobel Prize in Physiology of Medicine for his work in the field of reproductive endocrinology. Now let's look at 21st century trends and where are we today. So vitrification for embryos and oocyte cryopreservation can be done. There is time lapse, which is commonly known as embryoscope. There is artificial intelligence technology in the labs, social egg freezing. Again, it is at a great pace, it is happening. Oncofertility, something, cancer patients, some good which can be done through preserving their fertility while they go for chemotherapy and all, both for males and females. This is something which is really, really superb thing over the years, which has happened in the field of IVF. And IVF success rate and global access continues to improve with evolving technologies. So we have personalized ovarian stimulation. Gamete selections can be done with artificial intelligence, even embryo selection with the help of artificial intelligence like Erica and all those things. Embryo ranking systems are available. And as I said, embryoscope, Erica, and non-invasive chromosomal screening. So, PGT and NICS, if you compare, there is a good concordance rate as well, up to 80% without touching the embryo. The media in which the blastocyst is growing, from that media, the DNA of the embryo can be separated and it can be looked for genetic problems. So isn't it a wow situation that the way it is evolving? So this is how embryo ranking looks like. If you upload the images of embryo on a software, and you can get the genetic scoring like of different blastocysts, and you can choose blastocyst for your patients. And then comes advanced genomic sequencing and editing the genes, which is highly advanced things. And maybe, this will be with our country as well in next few years. Then comes mitochondrial replacement therapy, which is very advanced thing. And it's like, the concept behind mitochondrial replacement therapy theoretically is, if defective mitochondria in eggs or fertilized eggs are replaced with healthy donor mitochondria, it will bypass maternal mitochondrial DNA mutation and enhance the cellular function. So just see where we are today. So around 3 to 4 countries are already doing this MRT, mitochondrial replacement therapy. And hopefully, within next 10 years, this technology, even in India, we are going to have this. And this can be done in 2 ways. So basically, the aging eggs, so there will be 3 parents to that child, some part from the mother's egg, some part from the donor's egg, and the father's sperm. So this news was also there in newspaper few days back. And if you go online, you will find that around 8 to 10 babies who with 3 parents are already born. So mitochondrial replacement technology can be autologous as well as heterologous, and especially for places where there's a lot of social inhibition with donor eggs and all. Here mother's own DNA can also be there. So IVF today, current trends, over 5 lakh babies are born worldwide via IVF every year, and 2.5 million cycles are happening annually, and this is recognized as one of the most impactful medical breakthroughs of 20th century. So IVF has evolved from experimental techniques to mainstream treatment. ICSI and IUI have already complemented each other for the success. Indian contributions are globally significant. From embryo transfer in rabbits to AI-driven IVF lab, the field continues to evolve. And on World IVF Day, we celebrate the scientific pioneers and lives made possible through IVF. So thank you so much for your kind patience. That's all for my talk.
Thank you,
Thank
Dr.
you.
Sunita. That was really, really wonderful. You told us each and everything. I just want to say 2 lines. One, we should thank our animal kingdom for offering their body to humans, since I am a vegan person. And secondly, artificial womb is also formed these days. A goat, baby, a lamb is born through artificial womb. So science is, it's going in a new direction. Thank you, Sunita.
Absolutely. Thank you. Thank you. So over
Thank
to
you.
you, Yukti.
Yes, ma'am, you've covered everything from history to innovations to artificial intelligence and CRISPR technology. It was a very informative talk. I didn't know IVF in humans actually started in 1973. Thank you, ma'am. So, talking about infertility and IVF, we cannot leave behind the male. So, to talk about how male infertility has evolved since beginning, we have none other than our ISAR president Amit Patki sir to talk about this important session. And may I please request Sujata Agarwal to formally introduce our speaker?
It is my esteemed privilege to introduce our national president, Dr. Amit Patki sir. We know he has got so many things, publications. I just want to say that he's a great doctor. He's a team leader. He's always smiling and encouraging youngsters, and he believes in making protocols, evidence-based protocol, and a very good evidence-based practice and a very fair practice. So, welcome, Dr. Amit Patki. We are looking forward to hear from you.
Thank you so much, Dr. Sujata. Uh, can I share? Yeah.
Sure, sir.
Yeah.
So I must say that Dr. Amit Patki, sir, we are blessed to have him as President ISAR. He's a person of great integrity and very inclusive. You know, he is so inclusive that any event, anything, any day, he would like to call all the state chapters, and we have group of all state chapters, and he always involves all of us in all national and state activities. Thank you, sir. Over to you.
Thank you very much. And thank you to Delhi ISAR. My regards to Dr. Sharda Jain and my love to all of you. And I hope to meet all of you in person tomorrow on the World IVF Day. And as I requested, if you all have your ISAR scarf or tie, please bring it with you, because we want to show our presence in major meetings. My happy birthday to Louise. I was very fortunate to meet Louise Brown because my consultant in UK was part of the team where she was born, and I had the good fortune to meet her in one of our meetings. So when we talk of how male infertility or male factor infertility has evolved, I think the routine semen analysis remains to date the first test that should be offered to the couples. It is the most important test for evaluating male infertility. Sadly, to this date, also, I find some couples where extensive investigations have happened on the female, but sadly, one semen report which is needed is missing. Having said that, although we say it is one of the important tests, at the same breath, I say it does not provide information regarding all functions of the sperm, nor is it sufficient for us to predict male infertility potential. We must also know that the WHO criteria of semen analysis have changed vastly over the last 2-3 decades. And presently, the WHO standards that we use for normal values in semen do not reflect the average values. Understand, it is the bottom 5% cutoff. In other words, it is the minimum standard that we require for pregnancy. We know that the semen counts worldwide have decreased over 50% in the last 50 years. We know that 15% of men who were suggestive of pre-diabetic or diabetic had an increased risk of hypogonadism, increased sperm DNA fragmentation, and severe cases also landed up with non-obstructive azoospermia. In addition to diabetes, we know obesity is another reason for oligospermia and asthenospermia. And we now know that contrary to females having low potential infertility, men who are found to have low fertility potential are more likely to have metabolic syndrome, and such men should be further investigated. We also know that prolactin can be raised in men, which can cause some amount of sexual dysfunctions. And the treatment is similar to what we give in women, dopamine agonist, or if you have large tumors, then you need surgery. The sad part is that those who have got idiopathic OA, no evidence of using androgens, HMG, HCG, anti-estrogens, prolactin inhibitors, and steroids, and hence such treatment should not be given empirically because sadly it can worsen the stage and more importantly delay the treatment that we should actually offer to these males. I also see a large number of men having scrotal Dopplers and USGs performed. However, this should be reserved to the small group considered strongly in patients with history of cryptorchidism or prior germ cell tumors or for men who have unexplained abnormalities on testicular examination. So coming to that testicular examination, I think it is very important that we do not treat only the semen report, but as we examine the woman, we should also examine the man for his general examination and then for genital examination. Routine scrotal ultrasound for subclinical varicocele is not recommended because such varicocele repair has not shown to be effective in improving semen parameters or fertility. So we should do a semen report, do a general examination and a genital examination to see for the testicular volume, to see for the testicular turgidity, to rule out clinical varicoceles and any other incidental findings like hydrocele or hernias or sometimes testicular tumors. As Dr. Sharda Jain and Dr. Sunita very effectively said, that ICSI, but we all know, was discovered incidentally in a Belgium lab, but it is a highly effective therapeutic intervention to assist fertilization in severe male factor infertility. And I think if I have to pinpoint which test truly revolutionized after IVF, it is ICSI because it treated almost most cases management of male factor, particularly severe male factor infertility. Now understand that ICSI bypasses the natural selection. ICSI did not have any vast animal studies to see what could be the cause. And then after a few years, we realized that ICSI can cause promotion of transgenerational transmission of genetic defects to the offsprings, causing gametogenic failure. And hence we know that it has a potential to negatively impact the genetic composition of the humans, and particularly in cases where there is severe OAT or azoospermia. Before we label somebody as azoospermia, we know that only routine semen analysis is not sufficient. We need to do two semen analysis, and more importantly, we need to centrifuge the sample and check the pellet, because in 2% of so-called absent sperms, once you centrifuge the sample, you will find few sperms and the diagnosis and the treatment completely changes. In azoospermia, it is important to do the FSH, the total testosterone, TSH, LH, prolactin. And if a biopsy is done, because quite often the patient lands up with andrologist and they prefer to do a biopsy, I think it is important to freeze this sample because you could use it later and prevent another biopsy at that time. Also, it is important to send a small sample for histopathology because 1% of patients with severe OAT and azoospermia have presence of carcinoma in situ, and you could actually save a patient's life besides giving them a family. We all know there are two major types of azoospermia and obstructive azoospermia, where there is obstruction and hence fructose negative, low semen volume because the maximum volume comes from the seminal vesicles. On examination, there is normal testicular volume. In some cases, you can find bilateral absence of vas, and only if you suspect there is seminal vesicle obstruction or ejaculatory duct obstruction would you want to do a transrectal sonography in such people, because surgeries can effectively open up this obstruction and save you the need to do advanced ART treatment. However, a maximum number of azoospermic patients are non-obstructive, which means there is no obstruction, fructose positive, normal semen volume. But when you examine such men, you find that the testicular volume is low, the testes are soft, there is flat epididymis, and if you have an elevated FSH, you know that this problem has been there for a longer time, and TISA or TISA or micro TISA, as the case may be, is the effective treatment. It is important that to do genetic testing in these men on the Y microdeletion and normal karyotype, because 7% of severe OAT and 15% of azoospermic men can have Y microdeletions or abnormalities in their karyotype. Now, what is Y microdeletion? The Y microdeletion is the AZFA, B, and C, which is concentrated on 5 and 6 on the Q arm, which is the long arm of the Y microdeletion. But these are not the only areas or genes which code for spermatogenesis. You have other genes like DAS, RBM, or DFFR genes which are also associated with male infertility. Why it is important to do Y microdeletion? Because if you know which deletion is there, then you know what is going to be your chance of getting sperms. You know that if it is going to be A and B, you would not get sperms, and with C, there is chance of getting sperms. Later on, we started doing fish on sperms because we knew that some of them would have disomies, which is because sperms are supposed to be haploid, have only one set of chromosomes. When you find that there is disomy or there is XY in the sperm, you know you are going to get abnormalities in the embryo. We also know that if a biopsy is done, even if there's one area of hypospermatogenesis, you have a good 80% chance of retrieving sperms. When you know that there is going to be a maturation arrest, even in those cases, almost 40% of them will give you sperms. And now we know that even if there is diagnosis of Sertoli cell syndrome, 25% of sperms can, 25% of the times you can retrieve sperms if you go ahead and do micro TSA. There was some thoughts and some school of thought that you should be using the sperms which are retrieved from the testes in patients who have got severe OAT, because these are the sperms which do not have high DNA fragmentation and would give us better quality of embryos, better implantation rates, and lower miscarriage rates. Now, I would like to put a word of caution that if you have men where there is OAT or there is high DNA fragmentation, it is important to investigate and see what could be the cause. Some of them have metabolic syndromes like obesity, diabetes, hypertension, stress, smoking, alcohol. It is worth telling them lifestyle changes, as we tell a woman with PCO, put them on antioxidants, make an effort to get their sugars normal, lose weight. Despite all this and addition of antioxidants, if the sperm DNA fragmentation still continues to remain high, then we could think of using the sperm from the testes, because we really do not know what are the epigenetic changes that can happen in such babies and which can be found only in their third, fourth, or fifth decade of life. So now I come to a test which is evolved, which is the sperm DNA fragmentation test. And in my mind, it is a window to not only fertility, to a man's health. And why do I say this? Because I had an eye opener when I read this paper of Ashok Agarwal, which said that 15% of patients with male infertility were actually found to have normal semen reports. So the semen report that I feel should be the first test. It is still very important. But if you have a man who is obese, who has got lifestyle issues of smoking, alcohol, diabetes, hypertension, I think it is important to correct all these as we would advise in a patient, in his wife, because we know that 15% of patients would fail because of male factor, which is undiagnosed. So selection of sperms with high DNA fragmentation can result in undesirable effects, giving us lower pregnancy rates, high miscarriage rates, or even to go further, some amount of epigenetic and genetic defects. We have seen, especially in advanced paternal age now, that when men father children after the age of 45, but definitely 50, we see a large number of mutational changes giving us rise to ADHD or childhood cancers in such children. So we know that sperm DNA integrity is crucial for fertilization and development. And we know that the ROS is increased, and we know it can be increased with varicoceles, with genital tract infections, obesities, with previous radiation and cancer treatments, with environmental pollutants. Some of this we can control, some which we cannot, but it is important to tell the men that they also need to have lifestyle changes. There are various tests. I don't think time prevails for me to get into details, but the benchmark test is a tunnel test, which is very difficult, very expensive. So most of us would use the indirect sperm chromatin assay or the sperm chromatin dispersion test. We know that if the DFI is raised, we have complicated pregnancies, and if the DFI is more than 40-50, the pregnancy rates are abysmal. We examined 100 such men who were referred to us with previous IVF failures and in whom male infertility was not documented, and we found that almost a fourth of them were over the age of 40, 20% diabetic, 12% hypertensive, thyroid issues, obesity with a BMI of more than 39, heavy smokers, alcoholics. We also found some of them were on chronic medications, and some of them were on these supplements, especially create powders in high protein diets, which were used in their gym training. So lifestyle modification, reduction of weight, treatment of diabetes, alcohol, simple things like wearing loose underwears or avoiding high temperature environments, controlling male factor infertility, because we know when there are inflammatory cells, there is increase in the ROS, and this can further cause DNA damage. So when you see pus cells, you treat them for 2 weeks minimum with very simple antibiotics like doxycycline. This will get the WBC down in the sperms and thereby giving us better. We have been giving oral antioxidants. Most of us have been using it empirical for want to give something to the male, but we now know that certain antioxidants are important because they help to reduce the DNA fragmentation. Cheap antibiotics like vitamin C, vitamin E, and expensive ones like coenzyme Q10, zinc, L-carnitine are all very effective, and we know that there are products in the market giving a combination of all this. But this needs to be started at least 2 to 3 months before, because we all know that spermatogenesis takes around 85 to 90 days to happen. And for any good effect, we need to go through the full cycle of spermatogenesis. Why oxidative stress is important and DNA fragmentation? Because it can be potentially reversible, and this gives us an opportunity to treat such men by lifestyle and by antioxidants. So proper nutrition, lifestyle, antioxidants are the cornerstones for treatment of male infertility. This is one of my favorite slides because it exactly shows you which antioxidant, which micronutrient affects the sperm head, the mid piece, and the tail, and it is extremely important to put such men. Varicocele repair should be offered in men in whom it is physically palpable, and more important, the testicular volume and the turgidity is normal. If the varicocele is present in men with very small, impalpable soft testes, such varicocele repairs eventually fail and can bring more sadness or concern or distrust in the patient. Micromanipulation techniques for sperms, we know that we started with swim up, then we moved to density gradient. Now we have got magnetic sperm sorting, high magnification. We have got sperm selection techniques like where we can do sperm selection like doing PIXI or using better techniques. We also know that testicular sperms are better, but use them with caution only after you have tried various different methods. And we know that it will give us a better reproductive outcome. Simple things like short ejaculatory abstinence also helps to reduce the ROS and DNA fragmentation in the sperms. PIXI using hyaluronic acid and various microfluidic devices help us to choose the sperm and give us better successes even in IUI, in IVF, and in ICSI. Avoid prolonged incubation, prolonged centrifugation. Avoid using cryopreserved sperms because we know that will cause a problem and increase DNA fragmentation in certain patients. And using of IMSI, high magnification, is important. So to end my talk, there has been a very great evolution from simple sperm semen analysis to advanced techniques to advanced methods to advanced devices which are important, but simple things like lifestyle, weight loss, stop smoking, reduce alcohol, antioxidants also go a long way in helping us to conquer male factor infertility. I end my talk here with profuse thanks to the Delhi ISAR President Dr. Sunita, Dr. Seema, Dr. Sujata, and my gratitude and regards to Dr. Sharda Jain. And I'm really fortunate to have her when I speak. Thank you very much.
Thank you
Thank you.
so much, sir.
Thank you for giving us such a comprehensive review of how, we evolved as far as male fertility is concerned. Very, very informative. And thanks for being there and for sparing your time, sir, for this special day for us. Thank you. So we will quickly move on to the next talk now. And as you all know, hysteroscopy is an integral part of IVF, isn't it? And hysteroscopy is close to our hearts as fertility specialists. And we know so many things, especially cases of recurrent implantation failures and all, where 3D scan is showing you one problem or the other. If you do a hysteroscopy, you kind of go towards success in quite a few number of cases. And we are lucky to have Dr. Renu Mishra here, who is President HSI. Dr. Yukti, can you please project the slide, and can we request our chairpersons to
Okay,
complete
thank you, Sunika. I will share my slides. Thank you. Can you see my slides?
Yes, we can. Dr. Shelley, please read out Dr. Renu's CV for us.
So your
No,
slide is
wait.
not visible.
Let me share my screen.
Ma'am, can you
No.
Yeah, we can
Shelley,
see your
please
slides, ma'am.
stop sharing.
Hi, so it is my proud privilege to introduce Dr. Renu Mishra, who actually requires no introduction. She's a very respected senior of ours She's the director, Kamna Fertility and IVF in Gurgaon, and a senior consultant in obstetrics and gynecology at Sitaram Bhartiya Hospital. And she has held the position of additional professor at AIMS. She is the founder president of the Hysteroscopy Society of India and even the past
Thank you,
president
Shelley.
of
I think
Delhi
we move on.
Gynae Forum. Okay, ma'am. I would have loved to have gone on and on, but then I guess.
Thank you so much, Shelley. Thank you so much. Some other time. If you stop sharing, I will share my screen.
Yes.
Okay. Okay, so good evening, namaskar. At the outset, I would like to thank Delhi ISAR, Dr. Sunita, Dr. Sujata for giving me this opportunity to be part of this World IVF Day celebrations. And after hearing the stalwarts, Amit sir, Dr. Sharda Jain ma'am, Dr. Sunita, and showing us the roadmap how IVF evolved, I now take you a brief journey how hysteroscopy evolved. As we all know that hysteroscopy has become an integral part of diagnosis and treatment of infertility now. So in the field of medicine, and I would say in any field for that matter, progress is driven by the imagination of pioneers and the dedication of subsequent researchers. Endoscopy as a medical philosophy rests on the belief that the most effective way to diagnose and treat diseases is through direct visualization. Like we always say, seeing is believing. What is the problem? Okay. So the history of hysteroscopy goes back to 200 before Christ, 200 years before Christ, when we see the first report of an attempted hysteroscopy in a Jewish religious textbook called Talmud, where it described a lead drainage tube inserted into the vagina. 1805, Bosny, which is supposed to be now the father of endoscopy, built the first endoscope. But as has happened to many brilliant researchers, the Vienna Medical Academy suspended all of Bosny's research and killed an academic excellence. And unfortunately, he died of typhoid fever at the age of 35. Pentiloni, who first did a proper uterine endoscopy in 1869, did it to a patient who reported with postmenopausal bleeding, and he diagnosed and treated her endometrial polyps using a silver nitrate strip. 1879, Nidze, a Viennese urologist, introduced cold light, and in 1898, we find the first scientific record of hysteroscopic findings. As you see in this picture, this is from the same book, which was called Operative Surgery, and this is by Duplay and Clado. Moving to 20th century, in 1925, Rubin first used carbon dioxide to distend the uterus because they found that it was not easy to distend the uterus as it was easy to distend the bladder. At the same time, Gauss was experimenting with sodium chloride using fluids for distension. In 1947, Norman developed contact hysteroscopy, putting the light at the proximal end of hysteroscope. In 1962, Cylinder used a double-channel hysteroscope so that you could have a continuous irrigation and outflow channel. In 1965, the fiber optic cable came with xenon light source. And in 71, Mori introduced the first flexible hysteroscope. While the equipment evolved, also the procedure evolved in 20th century. In 72, we find the first description of transcervical catheterization of fallopian tubes. In 76, Neurith and Emin, they first did the successful myoma resection. In 1980, Hamu introduced the microcolpohysteroscopy, which did not take off very long. And Goldreth in 1981 did the first hysteroscopic laser ablation of endometrium. 1982 was a landmark year because that changed the way we do endoscopy now, because in 82, we got the first video camera with monitor. And in 89, Bagish did a hysteroscopic myomectomy using an ND-YAG laser. So by the end of the 20th century, hysteroscopy had already eroded into the traditional long-standing DNC procedure. And we started seeing articles like these. This was in the Journal of Royal Society of Medicine, which said the demise of DNC, which is not entirely true, but certainly we have done away with DNC in many of the conditions. Office hysteroscopy was introduced by Bertocci, and this was the first office hysteroscope which he introduced, which had a 2 millimeter diameter endoscope, and with the outer sheath and the operative channel, it was 4 millimeter, so that office hysteroscopy could be done without dilating the cervix. Bertocci also introduced the concept of vaginoscopy. These are some of the instruments which were produced by Karl Storz. The top one is the Bertocci's operative hysteroscope, which has an irrigation outflow, and it has a side channel through which you can put electrodes or a grasper or a biopsy forceps or a scissors. And this is a trophy scope, as it is called. So the lens is still 2.9. You can go inside the 2.9 lens. And if you have to do an operative work, the advantage with this scope is that you don't have to take it out. You can just slip on the operative sheath over the diagnostic sheath. So it saves you from taking out the hysteroscope and going back again, which actually spoils the vision a little bit. 21st century, we saw that the equipment which was made till now saw very sort of fine tuning. The scopes got thinner, cameras became high definition. We got newer versions of Hystromat. We also had bipolar compatible hysteroscopy. The earliest of these was produced by Johnson & Johnson, called the VersaPoint, what you see in the picture on the right side. And it produced a twizzle, an electrode, so that you could use normal saline for electricity rather than using glycine, as we had used all along before this for monopolar electricity. Hysteroscopic morcellator is probably the last of the addition to these gadgets. So that is how it works. Sorry. So this is a mechanical morcellator which sort of nibbles small polyps or myomas, and it also flushes the uterine cavity so that the cavity remains clear and your vision is not marred. These are some new generation instruments. People are now making newer kind of graspers to suit what they want to do in the outpatient hysteroscopy. So you can have new graspers. You can have this grasper with a spike so that you can poke it into a myoma and then pull out the myoma like you do it in open myomectomy. This is snake biopsy forceps. This is a palpator with a centimeter gauge so that you can measure your septum, how many centimeters it is, and give a little bit more objectivity to your subjective diagnosis of how big is your septum. So these are all obviously things that are now coming up. Briefly, I will tell you my journey of hysteroscopy. So my exposure to hysteroscopy started in 1993 when I was awarded Commonwealth Scholarship by UK for 1 year. I spent 6 months in Leeds General Infirmary and 6 months in Whipps Cross and North Middlesex in London to learn laparoscopy and hysteroscopic surgery. Just to point out some interesting observations, when I was in Leeds, the commonest operative hysteroscopy that was done in Leeds Theatre was TCRE, which we never saw in India. It never picked up really because probably because it has a much longer learning curve. Probably patients are more brainwashed for hysterectomies, but I hardly saw any hysterectomies there, and it used to be more of TCREs. And interestingly, women who had some respite with TCRE for a few years came back to redo TCREs, which I have seen nowhere else but in Leeds. Every OT, there was a redo TCRE where they still didn't want a hysterectomy and they would have another TCRE. At that time, they were also having a nationwide study comparing resection and rollerball ablation for TCRE. Whipps Cross Hospital, the highlight of my training there was an evening outpatient hysteroscopy clinic, which I used to do twice weekly from 6 to 9 p.m. We didn't have the 2.9 millimeter telescope. It was a 4 mm telescope. So with the irrigation channel, it becomes 5 mm. 10 patients were slotted, 20 minutes per patient, single-handed. I did no analgesia, no anesthesia, no misoprostol, no dilatation. About 8 to 10% of these patients had to be posted under anesthesia, whether I could not negotiate the os because it's very tight or adhesions, or there was some intrauterine pathology requiring operative hysteroscopy. At AIMS, we did our first live surgery workshop in July 1995. In fact, that was the first ever live surgery workshop conducted in AIMS. And then from then on, I did yearly hands-on training workshops dedicated for hysteroscopy. We got a training center at AIMS. The lab equipment, that means the camera, the equipment, the monitor, everything was donated by Karl Stores. And the most recent venture, like Dr. Sunita said, we have launched Hysteroscopy Society of India, which is a pan-India society, which got registered in 2023. These were few of the publications which I had while I was in AIMS. Elix evacuator is a simple mechanical device to flush out the chips, which you can do now with these tissue retrieval systems, vaginohysteroscopy, and we did a thesis comparing the Mirena to TCRE and seeing which one was more effective. Now the question is, what does the future hold for hysteroscopy? So first of all, the focus is on operative hysteroscopy in office settings by reducing diameter of the instrument, by improving patient experience and safety, improving image quality without increasing the cost. The next thing which is on the horizon is digital hysteroscopy clinic. This has been developed by Rudy Campo from Belgium, who has integrated 3D sonography into the endoscopic tower in 2018, but I don't think it is commercially available in many places. 3D hysteroscopy, of course, I was sure it was going to come with after 3D laparoscopy. So because all it needs is addition of 3D image visualization. So that is also on the horizon. We will be getting 3D hysteroscopes. AI integrated hysteroscopy, well, AI is permeating into every field. So this has been now developed to reduce the subjectivity of the hysteroscopic assisted pathology. Like most of the time, it is a very subjective assessment when we look at the endometrium and say whether this is secretory or this is hyperplastic or this is proliferative. So this will probably enhance or get in some objectivity into the correlation with the final histopathology. Robotic hysteroscopy, robot क्यों पीछे रह जाएगा? So robotic hysteroscopy, Harvey et al. Have developed a prototype for a 23 French rigid system enabling two-handed surgery in a simulation laboratory. It is part of feasible study for endoscopic robot for hysteroscopic applications. And so this is how the journey of exploration of the uterine cavity continues. Thank you very much.
Thank you so much, ma'am, for taking us through the journey of hysteroscopy. And a big thank you to all the speakers. We have learned about the IVF journey in India, how IVF is involved since conception, hysteroscopy, and also male infertility. So thank you to all speakers. May I
request our chairpersons to give us one-liner concluding things. Dr. Birbala, ma'am.
I think it was a wonderful, wonderful session. And we've learned a lot from all of the speakers. And
Screen, Yukti.
I think it was very wonderful, totally.
Thank you, ma'am. Thank you for your presence. Dr. Deeba, Dr. Sushila.
Dr. Seema Prakash.
Yeah, so it was a very nice.
Yeah. Yeah, it was a very wonderful, the whole webinar was really wonderful. Dr. Sharda ma'am, she made us all proud by telling us the history in such a detail. And it was really a very good, in fact, very good oration, I would say, that she told us everything about how India is a leading factor in infertility practice. Then Sunita, she has given everything so beautifully. She explained from history to the present day, what is going on and what is the future of IVF in India. And then Dr. Renu Mishra, she has spoken so well on the topic she was given, and it is almost a complete talk on hysteroscopy and everything she has talked about. And last but not the least, Dr. Amit Patki sir. I have seen him talking about male infertility. And as such, male infertility is my field also, because way back in 96, when I was choosing my thesis, I was choosing ICSI. Then my guide, Dr. Geeta, told me that you will have to go to US to do that thesis. So that day, I still remember that since that day, I did my thesis in male infertility and oxidative stress. And Dr. Amit Patki, every time he stresses so much on oxidative stress and antioxidants in male infertility. And it was really a wonderful talk. And this webinar, Sunita and Sujata, I must congratulate you. Being a part of this team only, I am also a vice chair with you. But you, both of you,
organizer.
yes, I am also a part of this team.
Dr. Shelley.
But you too really work hard on these.
Thank
so
you.
congratulations.
Dr. Shelley.
So I'll just keep it very short. It was a wonderful presentation from all the speakers, right from the simplest of things to what all is there on the cards. And I think as Indians, we must be very proud, because we have a long way, that we've had in terms of history of IVF till the time that we are into the future. So it was a wonderful, wonderful experience. Very different.
Dr. Deepa, thank you, Dr. Vanna. Any message
Yeah,
for
it
on
was
World IVF Day? Please don't say that everything was wonderful. Say something else.
Something new.
No, it has been
She means
it has been
everyone
a
has to be
webinar to make us
specific.
very proud, make us really, really proud with our history, and
Yes.
now the big leaps which are being taken. And I really know that India will take us way ahead, as ma'am has visioned that it'll be a Viksit Bharat, even in the field of
Dr.
infertility.
Tarani ma'am is there. Dr. Tarani, Dr. Deepa, Dr. Deepika.
Dr. Shivani is there.
Yeah, it was a very short and crisp presentation by all the speakers, especially about the lesser known facts about infertility, about male infertility, about the history which we didn't know so much. So thank you, Dr. Sunita and Dr. Sujata, for giving me
Dr.
this opportunity.
Sunita, I'm here. Dr. Sunita.
Ma'am, we
Yes, ma'am.
need
Yes,
to
ma'am.
hear from you on World
Yeah,
IVF
yeah.
Day for
So,
our audience,
I
for our
must
Delhi ISAR
congratulate to
members.
both of you, Dr. Sunita, chairperson, and Dr. Sujata, secretary, and all team, taking the ISAR flag very high. I'm really proud of being here, listening to all our legend, Dr. Sharda Jain ma'am, Dr. Amit Patki, Dr. Sunita, and Dr. Renu Mishra. Dr. Sharda Jain made the thing so interesting and simplified. I really feel very proud. And Dr. Amit Patki really, he also very beautiful talk on the male infertility and especially on the ROS, why the antioxidant are very important. And Dr. Sunita, your thing was very, very interesting, lucid talk. You covered A to Z, everything of the advancement in the IVF. And Dr. Renu Mishra, really, she spoke very well and smooth about the hysteroscopy.
Thank you,
So
ma'am. Thank you.
congratulations to the team, especially Dr. Sunita and Dr. Sujata. And thank you so much for giving me opportunity. Thank you so much.
Ma'am, for being
Okay, dear.
there.
Okay,
Dr.
bye.
Deepika.
All the
Shivani
best.
is there.
So,
Dr. Sunita, Shivani.
Dr. Shivani.
So thank you so much, Dr. Sunita, Dr. Sujata. Yes, ma'am. Ma'am, bolna cha rahi
Deepika, after Shivani, you speak after Deepika.
Yeah. So thank you so much, Dr. Sunita, Dr. Sujata, Dr. Seema, Dr. Yukti, for giving me the opportunity. Thank you so much. So yeah, ma'am ka Dr. Sharda Jain's talk was all heart. She brought us told us about the unsung hero. That was something new, really. I didn't know about that. About Dr. Mukherjee sir, that how his contribution. He can be called the father of IVF in India. That his contribution was not recognized till after he passed away. And then Dr. Sunita Arora went from there to pure science, innovation, PGD, and the MRT, which is going to be coming soon, probably in India at some point of time.
Then Dr. Amit Patki sir's class was truly a master class on male infertility. And ma'am, Renu Mishra ma'am, you were just excellent. You also traced all the history of hysteroscopy and your personal journey. That was very inspiring. कि आपने कहाँ यूके में किस तरह से how you learned from initial part of hysteroscopy and then how the department was set up in AIMS with Carl Stroh's donating the instruments. And ma'am, आप कहाँ से कहाँ तक IVF पहुंच गया है with hysteroscopy, with everything. And of course, as Dr. Vandana is just saying, we are now in जैसे leaps and bounds में हम आगे जाएंगे. Dr. Sharda Jain said कि we are now second in the world with IVF. So Viksit Bharat में, I think that should be the dream that we will be first in the world with IVF.
Right.
Thank
Thank you. Shivani, you want to say something for Delhi sir?
Yeah, I just wanted to say कि so many couples जिनके पास सिर्फ adoption option था और कोई option ही नहीं था because of advances in infertility, even for us that we have seen in 10 years in micro TISA with stem cells for uterine factor, हम adoption के लिए बोलते थे, and now these people can have their own children. So there are huge terrific advances, but at the same time there are so many limitations because we make excellent embryos but we are not able to cross that barrier of implantation. So we have come a long way, we have a long way to go, and all the presentations were great. And I wanted to add about Mukhopadhyay. He froze the embryo, he froze the egg. I mean, he deserved the Nobel Prize. He was like leaps and bounds ahead, and that is what we are doing now. We have gone back to the past where we are using frozen cycles. So thank you, everybody.
Thank you,
Shivani.
So
Dr.
I
Sharda
think-
Jain ma'am, I think has left, right?
Ma'am is there.
Ma'am is there? She's not there.
She was there.
Can I just congratulate all the IVF specialists and embryologists on this World IVF Day, or the eve of World IVF Day. So everybody is working hard, and good luck, because we are also in difficult times now to practice IVF.
Thank you,
We
ma'am.
have
Thank you, and same to you.
announcement, but we still have difficult times.
Same to you, ma'am.
Right. So, so we have our UNS team people with us, and Dr. Manish is there. So Dr. Sujata being secretary, and she has to give a vote of thanks. But after that, I'll request Dr. Manish also, because he also wants to say something. So after Dr.
So I think I
Sujata,
will let him
it
say
over to
first.
Dr. Manish from UNS team. So we are really grateful to them for giving us this platform, and it was flawless. Thanks to Mr. Rajendra, thanks to Dr. Manish, Dr. Shruti, and Rishikesh from UNS.
Thank you.
So, ma'am, do you
Am I
want me
audible
to
or not?
Manish after that.
Yeah, ma'am. So, do you want me to say something, ma'am?
Yeah, if you want.
Yeah, please, Dr.
Yeah, ma'am.
Manish, go ahead.
So, sincere thanks from UNS team out here. Just want to highlight one interesting fact about the first IVF baby. Louis Brown, as we all know, had an interesting middle name. And that middle name was given by Dr. Patrick, who had delivered her through a cesarean section at the stroke of midnight, close to midnight, some 47 years back. And her middle name goes like Louis Joy Brown. So that was the word joy he chose because she was supposed to bring joy to the world. And that's what at UNS, my colleague Rajendra Sharma, who is the GM, my colleague Dr. Shruti, and myself, Dr. Manish, we and our team try to bring joy of parenthood to each and every couple which visit your clinic, and we try to help through our products which we deliver through our sales team out there. Ma'am, if you allow me, I'll request my colleague Dr. Shruti to express some words of thanks, if that's okay, ma'am.
Yeah, sure.
Shruti, over to you.
Yeah, thank you so much, Dr. Manish, and thank you, everyone. So, good evening. It's almost a good night for most of us, actually. But yeah, my name is Dr. Shruti, and I'm from the Medical Affairs team at Universal Nutriscience UNS. UNS is a leading and continuously growing science and evidence-based nutraceutical company. We proudly support fertility health with a focused range of products, particularly in the segment of CoQ10, like CoQ Man, CoQ LC, CoQ300, and so on. On behalf of the entire UNS team, I extend our heartfelt gratitude to each one of you for being a part of the ISAR Delhi IVF Day celebration. A special thank you to ISAR Delhi for giving us the opportunity to serve as the academic partners for this initiative. We are deeply grateful to Dr. Amit Patki sir, Dr. Asha Bakshi ma'am. She could not be here today, unfortunately, but yeah, Dr. Sunita Arora ma'am, Dr. Sujata Agarwal ma'am, Dr. Seema ma'am, Dr. Yukti ma'am for their unwavering support and guidance with this. Our sincere thanks to all the esteemed faculty members for gracing the event with their presence. A special note of appreciation to our speakers, Dr. Sharda Jain ma'am, Dr. Amit Patki sir, Dr. Sunita Arora ma'am, Dr. Renu Mishra ma'am, for their enlightening sessions that beautifully captured the evolution of IVF, male infertility, hysteroscopy. It was a great and a gentle reminder to ourselves that with all the advancements happening around, even with PGT and MRT, India has truly today become a global pehchan icon for IVF. And finally, thank you to all the amazing participants for taking the time to join us today and making this celebration a success. Thank you once again, and we look forward to many more such academic collaborations in the future. Thank you so much.
Thank you, Shruti. And once again, a very big thank you to one and all who joined, delegates, as well as all our faculty, Dr. Sharda Jain ma'am, Dr. Amit Patki sir, Dr. Renu for taking out time and for their deliberations. Thank you to all the chairpersons. Special thanks to UNS team and to Secretary Delhi SAR, Dr. Sujata, who anchored the program, Yukti and Rashmika, good coordinators for the program. So thank you to all. And I will say that we are very proud to be IVF specialist, reproductive endocrinologist, infertility specialist. So big congratulations to all of us. And we really feel so delighted when childless couples, they come to us and we are able to help them out through our treatments and through the intricacies which have evolved over years in the world of IVF. So thank you so much and a very good evening to all and a very happy World IVF Day to all. Thank you.
Thank you for the opportunity, Sunita. Thank you.
So thank you, Dr. Sunita, and congratulations on World IVF Day to all the IVF specialists.
Yes, this is for everybody. Thank you. Thank you.
Thank you and good night.
Okay, good night,
And happy
everyone.
World IVF Day
Bye,
to
bye.
everyone.
Yeah.
Have a good night's sleep. Good night.
Bye.
Thank you.
Good night.
Thank you,
Bye-bye.
everyone. Thank you,
Bye.
madam.
Thank
Thank you,
you, ma'am.
Sunita ma'am.
Bye.
Bye.
Great.
Bye.
Yeah. So, Yogesh, you can